Hello, my name is Stephen Simpson and I am an advanced critical care practitioner working in Manchester, United Kingdom. Today's PowerPoint presentation is looking at the nurses and allied health professionals' role in the identification of sepsis. Learning objectives. To understand the nurses and allied health professionals' role in the identification of sepsis. And to understand the basic treatment concepts that nurses and allied health professionals can implement when patients have been diagnosed with sepsis. But why is sepsis so important? In The Lancet 2017, in a paper looking at global, regional and national sepsis incidence and mortality, it was estimated that there were 48.9 million cases of sepsis recorded worldwide, and this led to 11 million sepsis-related deaths. Sepsis is happening in your hospital, your ward, or your intensive care unit right now. In 2016, in the third International Consensus Definitions for Sepsis and Septic Shock, the definition of sepsis was clarified. Sepsis is now defined as a life-threatening organ dysfunction due to a dysregulated host response to infection. Identifying sepsis is very difficult. There are many signs and symptoms of sepsis, and patients may exhibit some or all of the following signs and symptoms to various degrees. New confusion. Patients may be sleepy, drowsy, or may have new confusion and be disorientated to time or place. Patients that develop new onset confusion need to be investigated. Patients may be tachycardic with a raised heart rate. They may have a temperature over 38.3 degrees and have rigors. They may be cold. They may be hypothermic with a temperature less than 36 degrees. Patients may often be tachypneic with a raised respiratory rate, may be greater than 20-24 breaths per minute. Patients may have a low blood pressure and be hypotensive with a systolic blood pressure less than 90. Patients that are having regular fluid balance may display a decreased urine output. Patients may often have a raised white cell count above 12 grams per litre or a low white cell count less than 4 grams per litre. They could have mottled skin, they could have rashes, and they may be blue and side-nosed. This is not an exhaustive list, and like I said, patients will often display various degrees of these signs and symptoms. To help in the identification of sepsis, there have been the development of many different scoring systems. These scoring systems were designed to help nurses and allied health professionals recognise when patients deteriorated. The two scoring systems that you can see are the modified early warning score system and the new scoring system. They give a score from 0 to 3 on parameters such as respiratory, pulse, systolic blood pressure, temperature and neurological function. The score then guides the nurses and allied health professionals and doctors to whether a patient may be deteriorating, and this could be with signs of sepsis. But these scoring systems can also be a little bit confusing. The Q-SOFA or Quick SOFA score was mentioned and discussed in the third International Consensus Definition for Sepsis and Septic Shock in 2016. This is a simple and easy bedside test that can be applied to patients to see if they have possible signs of sepsis. It requires no physiological tests and therefore is quite simply to apply. It looked at 3 elements: blood pressure, altered mental status, and respiratory function. Each element would score 1 point when a threshold was reached. A score of 2 or more with a confirmed or suspected infection would give acknowledgement that the patient may have signs of sepsis, and this would indicate they had an increased mortality of 10%. Hypertension. If a patient had a blood pressure of less than 100 systolic, then they would score 1 point. Altered mental status. If a patient was drowsy, sleepy, or had new onset confusion, they would also score 1 point. If a patient was tachypneic and had a respiratory rate greater than 22 breaths per minute, they would also score 1 point. These elements would be added up, and like suggested before, a score of 2 or greater suggests a greater risk of poor outcome with possible signs of sepsis. With the Q-SOFA or quick SOFA score, identify or suspected causes of infection are required. Common causes of sepsis can be seen here listed below. Pneumonia. This can be diagnosed on chest X-ray findings, positive sputum cultures, clinical findings such as crackles or cresps on chest auscultation, or patients requiring increased inspired oxygen and low oxygen saturations. Urinary tract infections. Patients could have painful micturition, they could have localized loin pain, or we could have a positive catheter sample of urine test or dipstick test. Patients may display abdominal pain or distension, and findings can also be seen on abdominal CT. Patient could have cellulitis, warm reddened skin, septic arthritis, swollen hot joints, or most common is wound infections. Any medical device or vascular device is a good vector for infection, and these need to be inspected daily. Patients could also have meningitis with altered neurological function or obvious rashes. All our patients can develop sepsis, but some patients have a greater risk. The elderly with weakened immune systems, diabetics, patients with chronic kidney and lung disease, patients that are diagnosed with cancer, and patients that are immune suppressed with medication such as chemotherapy drugs, radiotherapy, or patients with immune suppressing illnesses such as HIV. Sepsis is a medical emergency. The quicker we identify patients with signs and symptoms of sepsis, and the quicker we commence treatment, the better for the patient. Every hour a patient who's in septic shock doesn't receive antibiotics, their risk of death can increase by 7.6%. To help nurses and allied health professionals identify and treat sepsis in a timely manner, the Surviving Sepsis campaign, which started in 2002, developed bundles of care. These were made up of individual elements that were evidence-based and put together to help treat patients in an appropriate, timely manner. These guidelines have been updated every 4 years, and their aim is to reduce mortality in patients that have sepsis. The first Sepsis 6 bundle looked at giving patients oxygen, taking blood cultures, giving patient antibiotics, giving patient a fluid challenge, measuring patient's lactate, and a measure of a patient's urine output. These bundles of care and elements can often be seen on sepsis pathways. Many hospitals have developed their own sepsis pathway documentation, which aim to guide nurses and allied health professionals in the identification and giving the appropriate treatment at the appropriate time to patients that have been diagnosed with sepsis. Your hospital may have its own sepsis pathway and documentation. In 2018, the Surviving Sepsis campaign issues its latest bundle of care, which is ideally meant to be given in the first hour a patient has been diagnosed with sepsis. We aim to measure the patient's lactate. We aim to obtain blood cultures, and these are meant to be taken before we administer antibiotics. A patient is meant to receive a fluid challenge, and vasopressors such as noradrenaline are added to maintain a good mean arterial blood pressure. One, measure lactate. Lactate is produced by the body when the organs or cells in the body are not perfused properly, and it can be a good marker for a patient who's developing sepsis, or if we are giving appropriate medication and therapy in treating the patient. As soon as patient has been diagnosed with signs of sepsis, we need to measure a patient's lactate. This can be sent to a laboratory, or we can do an arterial blood gas. Lactate can be reassessed as required, and a lactate is elevated if it's greater than 2 millimoles per litre. 2. Obtain blood cultures. Blood cultures need to be taken as quickly as possible, and more than one set of cultures should ideally be taken. A peripheral stab using ANTT should be taken, and if a patient has a vascular device such as an arterial line, central line, or maybe a hemofiltration line, then cultures should be taken from these lines also. We also need to consider whether we can do a full sepsis screen. If a patient is chesty and coughing, or we can obtain a sputum sample. If a patient has got a catheter in, or can give a urine sample. If a patient has a drain, we should take some drain fluid. If a patient has a wound, we should take a wound swab. And if a patient has any sort of vascular device, then we should take blood from that. 3. Administer broad spectrum antibiotics. As soon as the blood cultures have been taken, we need to give a stat dose of a broad spectrum antibiotic. We should not wait for the regular medication time. Antibiotics need to be given within the first hour of a patient being diagnosed with any signs of sepsis. The antibiotic choice will vary from hospital to hospital and from the condition we are treating. However, it is recommended that a prolonged course of 70 days of antibiotics may be required. We may need to consider antifungal treatments as well. We may seek advice from microbiology, and maybe we need to review antibiotics once we have specific cultures and the blood culture results have come back. Antibiotics then could be stepped down to less potent antibiotics. Fluid challenge. To help maintain a patient's blood pressure and urine output, it is recommended that we give a fluid challenge. Patients with signs of sepsis may have hypotension and have altered renal function. A fluid challenge using a crystalloid of 30 ml per kilogram is recommended, and this should be given over the first 3 hours. As with any treatment, we need to reassess the patient. Are they fluid responsive? Has giving a fluid challenge improved the patient's condition? We also need to be aware that patients that have got signs of heart failure or have severe renal failure may need an altered fluid challenge. We need to be aware of a patient's hemoglobin, and if a patient's hemoglobin will drop less than 7 grams a litre, we may need to give a blood transfusion instead of a fluid challenge. 5. Commence vasopressors, such as noradrenaline. If after a fluid challenge or a patient has persistent hypotension with a mean arterial blood pressure less than 65 mmHg, we may need to start vasopressors. This is to prevent end organ dysfunction. Organs are very sensitive to blood pressure, and if a patient has a persistent low blood pressure, their organs aren't perfused correctly and they may stop working. Sepsis, if not treated quickly and appropriately, can develop into septic shock. Septic shock is a subset of sepsis in which underlying circulatory, cellular, metabolic abnormalities are profound enough to substantially increase mortality. And this was the definition of septic shock by the Third International Consensus of Definitions of Sepsis and Septic Shock in 2016. Most patients with septic shock end up being nursed and looked after in an intensive care unit. Nurses and allied health professionals need to be aware of other considerations in looking after these patients with sepsis. Patients with COVID-19 or adult respiratory distress syndrome may require lung protective ventilation. It has been shown that these patients also have benefit from being nurse prone, being nursed on their fronts. We need to measure the patient's urine output hourly. This is a good marker for end organ perfusion. If a patient is producing urine, we know that we are perfusing the patient's organs properly. Patients with sepsis may have a raised blood sugar. To help with antibiotics and managing infection, blood sugars should be kept within normal limits. Patients can become catabolic quite quickly and need a high calorie intake so they can recover from sepsis. Patients can develop stress ulcers and will need gastric prevention such as a PPI, proton pump inhibitor. Patients that are immobile in intensive care units can develop deep vein thrombosis, and good venous thromboprophylaxis is essential in intensive care patients. Communication between all nurses and allied health professionals and the medical team is essential in managing sick patients with sepsis on the intensive care unit. And finally, good, accurate record keeping is essential. Take-home message. Early identification and treatment of sepsis is essential. Antibiotics need to be given within 1 hour of a patient being diagnosed with sepsis, and these should be given ideally after a blood culture has been taken. We need to complete the sepsis bundle within 1 hour. Sepsis is a medical emergency, and patients with sepsis need to be treated accordingly. Thank you.